work with my colleague Hazem to perform one of the anti-reflux procedure. It's oral incisionless endoscopic fundoplication, TIF procedure. So one of the procedure can help our patients. We know reflux, one of the diseases need to have at least ultimate treatment. So one of the treatments is anti-reflux procedure. So today our job, me and Hazem, to demonstrate the device and then the procedure. Then we have to show you the end of the procedure. As it's a device, then with a scope, so you need two endoscopists and two operators, and then you have to collaborate with each other. And there is some of the requirements prepare it before you book your patient. You have to have anesthesia team, patient should be intubated, then CO2 of your endoscopy, and also CO2 encephalator from surgical CO2 encephalator to encephalate the stomach. You cannot do this procedure with air, never. So you need to have the CO2, and then you have to have both team and expert in the procedure, or they know, with the assistant and also with your team from the company.
Yes,
so this is the device?
Yeah. So before that, just to add a few points to you guys, the patient selection, as Dr. Abed mentioned, this is a straight TIF. So this is a patient who had refractory symptoms despite PPI treatment. He had no hiatal hernia and had a Hill grade of 1 to 2. So that's very, very important to select your patient who's a good candidate and will respond hopefully well to this procedure.
Good. So this is the device, as you see. We have very simple procedure. Initially, when you start to do this procedure, you think this is very difficult procedure, but at the end, after probably 10 cases or 12, reaching 20 cases, will be very second nature techniques. So this is the device. We have the helix. This is the helix to control or to grasp the valve. This is the fastener, how to load your fastener to 1 and 2. This is very important. You have to load before you start your process. Then we have the control, the wheels here. Then with the scope, you tell you where's the direction. And technique usually has we start from.
So once we go down to the stomach, we always try and get anatomy. The lesser curve being 12 o'clock, and then the greater curve being 6 o'clock. So we started, as you guys can see here on this side, this is the anterior, this is the posterior wall. We're going around 11 o'clock to create the length of the valve. Dr. Abed and I did already 3 firing of the fasteners, so total of 6 fasteners to lengthen the valve over there.
So we start from 11, we place a 3, then you go to the 1 o'clock, and you have to place or to deploy 3 fastener. Then you go back at 7 and 5 to go 2, total of 10. So you have to make sure about that. Now we are in 1 o'clock. Maybe you can show the device as you see. And then to the device, which is the evaginator. So now what you have to do, you have to close a little bit to make it very good control. And then you have to make the ramp. So I have to go anti-clockwise from 1 o'clock to go anti-clockwise and then clockwise?
Yes.
Clockwise, yes.
So it's always reversed. You want to, as Dr. Abed mentioned, anti-clockwise on the screen, but with your hand you go clockwise, and that will turn the view.
And you see, as Dr. Hassan now, you have to show me the endoscopic view now. So now it's good. Then after, go back. Yes. Then I'm just making the wrap now. We have to have a control with suction. Then evaginator on.
Yeah, evaginator on.
Yeah, and you have to make sure that you see. Can you show me the device here? Okay, show the device. More. See, that will you see the collapse of the device here. So that means the evaginator is already on. So you suck everything. Now we are happy to have good position to fire. Yeah. So there's a control for the fastener. Yeah, I have to push the device in a little bit because you have the measurement before. So you have to be away from the diaphragm. So we have to push. Good, now the measurement is good. Around the
38,
40. So You can show me the device there.
So measurement is paramount here. So you have to make sure when you fire, you're away from the diaphragm. So your fasteners don't go through the diaphragm muscle. And that can cause pain and complications like bleeding or hematoma.
So we are ready now to fire. So I have an unlock, and then I fire the first one. So we have to immediately load your devices. So this is the load. So you have to get back all the way back. And then you see the first mark is the black, then the second one, and then you are sure the device is out. Then you have to control the fastener. This is number one, and you hit the click. Once you hit the click, that means you loaded. And then the other one. And now you are okay to load all the fastener. So now it's okay to be safe to complete the second one. Now, I think initially, in the beginning, so we have to have two endoscopic performing the procedure to make it safe. And then if you train one of the assistants to hold the scope, it will be very good to help you. Sometimes difficult to have somebody to help you on the procedure. But
on, please.
Yes. Need two endoscopic to perform the procedure.
Good. I mean, as we know, the endoscopic management of reflux is an emerging tool. So many gastroenterologists, some of them will be keen to learn it and to establish it in their daily clinic work and endoscopy work.
So
we have a question from Dr. Hammad.
Diaphragm repair plus
section, please. Evaluation it on, please.
Plus TIF for patients who have large hiatal hernia or a Hill grade more than 2, 3, or 4. Okay. Those patients with large hiatal hernia or Hill grade more than 2 will not respond well to the straight TIF. Okay.
The outcome of the procedure, you have to make sure about the creating the valve. As, the valve already, if you see endoscopy before and after, you see there's a long creations of the valve, and make sure it's more than 3 centimeters, or at least usually 3 centimeters. This is the success of the procedure. No bleeding, nothing worried about the end of the procedure.